Hello, everyone. Welcome to the EASL Studio, your weekly hepatology broadcast news. My name's Debbie Shawcross. I'm a professor of hepatology at King's, and I'm also the current EASL Secretary General. And I'm very excited today that we've got a studio which is completely dedicated to PSC. And we've got an expert panel, which I'm going to introduce first, and then I'll give you a little bit of introduction as to what we're going to be talking about today. So firstly, I'm joined by Professor Cynthia Levy, who needs no introduction. She's a professor of medicine and in the Division of Digestive and Health and Liver Diseases, and is also an associate director of the Schiff Center for Liver Diseases at the University of Miami. I'm also joined by Professor Michael Trauner, who is a professor of gastroenterology and hepatology and chair of the Division of Gastroenterology and Hepatology at the Medical University of Vienna, who also needs no introduction, really. And finally, I'm delighted to be joined by Dr. Stephen Rossi, who is the current Chief Scientific Officer for the patient charity PSC Partners, which is seeking a cure for PSC. Stephen's overseeing their global research initiatives, including the WIND PSC Global Perspective patient cohort. And prior to joining PSC Partners, Stephen spent about 25 years working in the biotech space, developing new treatments for liver diseases. So he's going to give us a unique perspective on that and how that relates to PSC. So welcome, everyone. And just as a little bit of a prelude to the studio, and also I think in tribute to a wonderful colleague that we've recently lost, Michael Manns. Michael described PSC as the last black box in hepatology. And of course, it's a very rare progressive disease of unknown cause, really. And up until now, it's been frustrating because we've lacked some really efficacious treatments to slow or even stop its progression. You know, what we really want to do today really is to bring everyone up to speed, because not much has happened in 150 years, but over the last 2 years, there's been a real turning point in PSC drug development, including recently a positive NOR-ERSO phase 3 trial, which actually we presented at the EASL Congress last year. And what we want to do in the studio today is really to divide it into 3 parts. We're going to start by talking about the current diagnostic and treatment landscape for a patient who's living with PSC. And then we're going to move on to talk a little bit about the recent drug development over the past few years and why it marks such a turning point, and what does it mean for patients and also hepatologists alike managing them. And then in part 3, we're going to talk a little bit about the horizon, do a bit of horizon scanning really, and talk about what's exciting and what further developments we can expect over the next few years. So without much further ado, I'm going to start with you, Cynthia, if that's okay. And there's nothing like starting to think about this from a clinical perspective. And I wonder if you could sort of talk us through your treatment approach to a new patient who's maybe referred to your clinic with PSC. And I'm going to give you a little bit of a scenario just to help shape things. Imagine you've been referred a 28-year-old gentleman who's got a long-standing 7-year history of left-sided ulcerative colitis, but it's currently well controlled. But recently in his clinic follow-up, he's been diagnosed with raised alkaline phosphatase and gamma GT, and an MRCP which was organized has shown a sort of mild to moderate intrahepatic cholangiopathy. And you've been asked to sort of launch in and manage him. How would you go about doing that?
Yes, thank you, Debbie. Yes, first of all, I would like to thank you and EASL for this conversation and bringing PSC to the front line. Yes, it's always challenging when you talk about clinical practice and management, pharmacological management of PSC, since we all know there is no drug labeled for that indication. And the disease is so heterogeneous that truly we cannot say in PSC that one size fits all. So I'm glad you're giving me a scenario, and it looks like this patient has just been diagnosed and it's relatively mild disease at this stage. So my first approach is always to risk stratify when I have a PSC, I confirm the diagnosis, of course, and risk stratify this patient based on the degree of elevation of alkaline phosphatase, bilirubin, using non-invasive methods to assess liver stiffness, symptoms, all of that. So in a patient with normal or near normal alkaline phosphatase with early stage fibrosis, I will probably not start any pharmacological therapy for this patient and just monitor over time. However, if I identify a patient who is at higher risk for progression, so an alkaline phosphatase that is about a couple times upper limit of normal or bilirubin is elevated, significant intrahepatic disease on MRI findings or advanced fibrosis, that's when the challenge really starts for us. I always offer my patients participation in clinical trials. So at the Shift Center, I'm fortunate to have access to most of the studies coming up. And that's the only way for us to really identify an effective treatment in PSC. If the patient doesn't qualify or does not want to participate in a clinical trial, or if there's nothing available, then I tend to offer UDCA, ursodeoxycholic acid, at a dose of 15 to 20 milligrams per kilo per day and monitor for a response in 6 to 12 months. If we see such response, I will tend to continue that. And if not, I may discontinue the drug. And all of that in the context of bringing the patient into this discussion, right? Because we need that interaction. We need to let them know the drug is not approved for that indication and that we don't have proof that it will change outcomes. However, we do have some evidence that with improvements in normalization of alkaline phosphatase, we tend to see a lower rate of clinical events in PSC. So in terms of pharmacological approach, that's how I would go. There's a very small subset of patients I may consider fenofibrate for in the United States, especially if they have itching. But realizing that, again, this is off-label and not approved for that indication. So that's my approach for pharmacological treatment. I'm interested in seeing how Michael does that, and we can talk about monitoring and surveillance later on.
So Michael, would you do anything differently?
I think Cynthia really nicely outlined the scenario. I mean, risk stratification is key. FibroScan and ALF certainly is giving us an orientation, but I would tend to treat every patient, irrespective of the risk profile. So certainly at the moment, we don't have much else to offer than ursodeoxycholic acid, but I also would place patients with the low risk profile, so low liver stiffness and low alkaline phosphatase levels on urso, because I'm a strong believer then that, treating the disease early is key, especially in primary sclerosing cholangitis before the fibrosis really kicks in. One key question always is, and that's also the major concern the patients come to us, is there already cancer on board, right? I mean, first of all, could there be cholangiocellular carcinoma already on board at the initial manifestations? I would carefully review the quality of the cholangiogram, and actually, if there's any doubt, have an early recall of the cholangiogram. Sometimes, the the MRCs in the outside world, not the full protocols are run, and the quality is sometimes shaky. So early recall strategy, and also look carefully at the colonoscopy profile. Probably the patient with IBD has been monitored, but perhaps not, at the yearly interval. So I would carefully look back, when was the last colonoscopy? Also perform an ultrasound to look at gallbladder polyps or potentially also malignancy in the gallbladder.
And maybe if I could come back to you, Cynthia, you had more of a watch and wait approach. What would be the trigger points for you starting therapy? Would it be more symptom-based? Would it be more biomarker-based? You mentioned bilirubin and alkaline phosphatase. What would be the most important driver, do you think?
Not necessarily symptom-based, because we don't have evidence that also improves pruritus, for instance, in these patients. What I meant in this risk stratification, just to clarify, so if a patient comes in with normal alkaline phosphatase or near normal alk phos, we feel sometimes it's hard to justify starting the urso that early, and some patients don't want to be taking a medication that is not necessarily proven to change their outcomes. But I am open to prescribing that if that's what the patient wants. I always bring the patient into that discussion. So it would be biochemical and also liver stiffness. Certainly, if there is any evidence of progression of fibrosis, I hope to start before there is progression, but that would be a trigger, not symptoms specifically.
Thank you. That's really helpful to clarify. And you also mentioned that if you did start ursodeoxycholic acid, you'd start 15 to 20 milligrams. Now, there was some data a while back that suggested higher doses could actually be detrimental. Is that data still important for us to take on board? I remember when I was training, there was Keith Lindor published a trial to suggest that high dose urso might be actually quite detrimental.
Yes,
What are your thoughts on
absolutely.
that?
We strongly discourage, and actually both the European and American guidelines strongly recommend against using high-dose ursodiol, exactly because of this data showing increased rate of events and even increased rate of cholangio in patients with high-dose urso. So we discourage that for sure.
Okay,
Absolutely, we
wonderful.
never go higher than 20. The American guidelines are a
Yeah.
little bit more liberal, up to 23, but
Yes.
I think, you know, the range between 15 and 20 as outlined by the EASL clinical practice guideline is a good range.
So thank you. So that's a really important message for our listeners out there to just remember that dosage. So Stephen, I'm going to come to you now. And we've talked about sort of a little bit of a case scenario, but what are the major unmet needs for patients with PSC? You're a huge advocate for patients. What are they telling you are their unmet needs?
Yeah, well, I mean, I think Michael and Cynthia have highlighted a lot of the key issues. One is actually the lack of an effective therapy that can actually make an impact on their disease. But the patients actually, there are two things that really bring, if you want to call it anxiety, or where they feel maybe not being as addressed as best as possible. One is patient symptoms. And for a long time, I think there was, even especially with things like brain fog and fatigue, there was just not a really good understanding, if you want to call it, of the science of the symptoms. And we're really understanding there's like neuroinflammatory issues and things that actually cause a very PSC specific type of fatigue and brain fog that is quite debilitating to the patients. So I think the recognition that symptoms are significantly impactful, and that's really for people outside of like Michael and Cynthia who are very in tune to that, but the general, I think, care provider community is seeing that. The other thing is the top source of anxiety in patients, though, right now, believe it or not, is the unknowns of around cholangiocarcinoma, even more so than per se the progression of their disease in some cases. We've done some surveys that have shown that that is actually one of the top sources of where the patients feel a huge amount of anxiety around. And the last would be both access to care. At least in the United States, the majority of patients, PSC patients, are actually seen in gastroenterologists and aren't as well connected to the hepatology expertise with Cynthia and others. And we see patients bounce around quite a lot trying to get to the optimal care that Michael and Cynthia just outlined. And so I think those are three things we hear pretty consistently with that.
Can I piggyback on what Steve is discussing? This is so important. I think when we talk about, you're asking, how do I manage patients with PSC? And that pharmacological approach is just one tiny aspect of the global, holistic care of our patients. So yes, we look for that and we monitor for disease progression. We do repeat VCTEs or MREs on every 1 to 2 years, depending on the stage of the disease. We do all that. And we also have to address their symptoms, their concerns. This fear of the unknown is a major issue, as Steve is mentioning, and the patient community is bringing this to us, to our attention. not that we have to manage that as hepatologists, but we can address and refer as needed, just recognize that this is happening. And the same for pruritus, be attentive for possible episodes of cholangitis and manage them early. So that's the second aspect. And then the third will be the surveillance for malignancies, because unfortunately PSC is a pre-malignant condition. And again, it's the fear of the unknown from the patient's perspective, and from our side, just staying on top of it, as Michael pointed out. For those with PSC IBD, we need to do annual colonoscopies for these patients, maybe every 18 months if they're in deep remission for their IBD. There's some debate about that, but definitely surveillance for colorectal cancer. The issue of surveillance of cholangiocarcinoma is another one that we can discuss here, how to really do it and
So,
whether it changes outcomes. It's a very nuanced question that we can talk about, and what our patients want. But regardless, it's the tripod, right? We need to attend to these three different areas when managing the patients with PSC.
yeah.
Thank you. Some
Yeah.
really important points there.
Yeah, absolutely. I mean, with cancer surveillance, of course, we have to be aware we are also adding to the anxiety, but I think it's really important to do those yearly colonoscopies and also cholangiograms, also if we don't have much more to offer, and ultrasound. And I think patient empowerment is really key here, also addressing the unknown issues and also addressing fatigue. And also there are very good, web-based softwares which also help patients to deal with fatigue. I mean, unfortunately, most of those web links are in English, but actually, I'm always surprised how well educated also our German non-native English-speaking patients are and take advantage of those web tools. So also giving the patient, the feeling of trying to control the disease together. I think that's a key issue.
Yeah, I would say, I mean, we're presenting some of this at AASLD. You've brought up a really key point, which is having those conversations with the patients, no matter if they're tough or not. We did a survey, ended up with 600 patients, and only half the patients had had a proactive conversation about cholangiocarcinoma. And that's concerning when, and we all know why. It's, you finding that balance of not scaring the patient, but also finding, giving them context. But the challenge is they go to the internet. And so they don't have the context and the connection to experts like yourself who can put it into the right context. And Cynthia, you described how you handle sort of the surveillance, and you engage the patient to make a decision on here's the risk, here's what we can do. It's not perfect. Do you want to have it? And I remember you describing that, and the patient will connect to that immensely and really feel cared for and a part of that dynamic.
That's really important points there. So I'm going to just move the conversation on just a little bit, because I know we've got lots to cover. But just before we start talking about some of the new exciting treatments that are sort of coming or going to become available, Stephen, it's taken us a long time to get to a point where we've got other things to offer patients other than ERSO. And I think there's been, along the years, there's been a lot of abandoned drugs and therapies in trials. I mean, why do you think that's been the case, and what have we learned?
Yeah. Well, I mean, a lot of it is the challenges, and this is putting a little of the drug development hat on, is the challenges of having an early proof of concept signal, like what is actually demonstrating that this drug might work. And so we often do these short studies to try and look at biomarkers or other things that may predict outcomes. But it's been challenging to see, do those markers actually lead to a benefit? And we've seen that go on for at least, Michael and Cynthia know this, for at least 10 to 20 years. We've tried to find those perfect markers. I think it's also sort of tracking with our better understanding of the targets, and also, frankly, how well to actually hit those targets more effectively, either dosing, a lot of things around that. But a big challenge, and we've all faced it, is understanding what is actually the regulatory pathway to get a drug approved. And so we've really tried, I think all of us, the patient community, the clinicians, and industry has really tried to work closely with the regulators to help move to a more realistic approach to get a drug approved. There's, in rare diseases, there's hopefully the concept of regulatory flexibility to really hopefully move things faster. Our community has watched the agencies sort of bounce around and not really come up with a real clear pathway, but I think we're getting there. I think Michael and the phase 3 programs that he'll talk about a little bit is really going to make some differences in seeing that we actually have a successful trial that actually may allow us to say we've got a path forward. So, but the patient voice is going to start getting a lot louder around this, and really partnering again with people like Cynthia and Michael to really, I think, put what's really important out there, which is we've got patients dying without a therapy at this point.
No, that's so important. And Cynthia, I'm just going to go back to you just very quickly, because you said when you see new patients, you try to enroll them in clinical trials. How difficult is it to get patients into clinical trials?
Patients are very willing to participate. They want to be informed. There are challenges, though. It's not an easy thing because they have to get out of their routine. And being referral centers, patients come from a radius of 5 hours sometimes to come to clinic. And then imagine that they will come often to the research center to participate in studies. Sometimes that is a barrier. But in a broader sense, they're very willing to participate in clinical trials and to carry through with all the procedures that are necessary, MRIs, and they have even been in agreement with liver biopsies for several of our trials. Not that we want to do invasive tests, we want to move away from that as much as possible, but it's just to illustrate how much this patient community is engaged and really wanting to participate and develop therapies.
Oh, that's amazing to hear. So I'm going to move forward a little bit now. And Michael, there was some very exciting data presented at the EASL Congress in Amsterdam this year. And there was a phase 3 trial of so I think just over 300 patients were enrolled. Can you talk us through some of that data and why that might be a game changer now for patients with PSC?
Yeah, I think the most important thing, and Stephen already has alluded to that, is that the trial was positive. After decades of failures, a positive trial. This is, of course, very important for the patients and their families, but also for us as a community who already, was a little bit frustrated with all the negative trials. Of course, with PSC, it's an enormous challenge because of the heterogeneity. But this study actually demonstrated a signal, first of all, of stabilization of disease. So with norocolic acid, as it is called now, we still call it noro. So norocolic acid actually reduced the risk of progression by half. So basically 20% of patients progressed under NCA and 40% under placebo. And even more interestingly, 20% of the patients actually showed improvement of fibrosis. So I'm talking here about fibrosis, the Ludwig stage, as a surrogate of disease outcome. So very surprising for all of us, actually, liver histology is the best surrogate for clinical outcomes which we have at the moment. And this certainly was one of the challenges, as Cynthia alluded to, to perform liver biopsies in the context of a trial which is not part of our clinical routine. But I think there's a strong signal in terms of stabilization or even improvement of fibrosis, which of course we think is driving the disease progression. And the endpoint was a little bit more complicated. So it was basically biochemical improvement plus stabilization of disease stage. And of course, when you have a study which is running over 2 or actually in the long-term run, even 4 years, many patients don't return for liver biopsy, although our patients are highly motivated. But we had things like COVID going on, wars, Brexit, which I don't want to mention here. So a lot of obstacles which kick in the clinical reality, and in an intention to treat analysis, those are failures. So that's why, let's say, 15% of patients responded to this combined endpoint in the intention to treat analysis. When you really do a per protocol analysis for those who really had a second liver biopsies, it's 25%, so much higher percentage. But I think we have a good signal, and at least the beginning of a journey.
Wonderful. That's really exciting. And I guess I'm almost turning to Stephen now. If I'm a patient who's dialing in now, when can I expect to be able to access this therapy or other therapies?
We can only talk about what we know publicly at this point, but
Absolutely. Yeah.
the challenges are with Norso. Unfortunately, it will likely get approved in Europe based on the guidelines there. It's still a big question mark because the study wasn't able to be conducted in North America. And so we may have regional therapies available, which brings on a whole different set of challenges. And we've talked about it as a community because we can see patients from the United States or Canada wanting to go and get prescriptions in Europe and all kinds of challenges around that.
Mm-hmm.
So again, we're hoping that the success of the trial will open the eyes of maybe across the pond to the regulators to say, okay, there's a bigger picture here. With that. So, but we still have at least, what do you think, Michael? At least another year to 2 years before it might be available. I don't know.
Well, I think it's no secret that NCA has been filed with EMA for conditional approval, but hopefully there will be some flexibility also of the regulator. So basically, we should have a clear response or a clear picture by the mid of next year, I would say. But certainly the challenge is, will this be just conditional approval, or, maybe there's some flexibility of regulators. Also, it's very difficult to conduct trials which also prove clinical outcomes. We've seen that with PBC, which is a much less heterogeneous disease, how difficult it is. And hopefully also, FDA will be more open to the data coming from Europe. Certainly, obvious things such as ethnical diversity needs to be addressed, but that could be done by short-term safety studies, and those are issues which need to be addressed. But there's a way around it.
And would this be prescribed as a monotherapy, or would this be an add-on to existing ERSO? That's a $1 million question. Maybe Cynthia could cover that one.
Well, I think Michael may be better to, but I think it sounds like a combination. If patients were on URSO already, especially, we can add the NCA. They seem to have additive effects, but Michael can comment on that also as subpopulations from the study.
I think at the end, the way this is going for a complex disease such as PSC, at the end, I think we'll combine therapies. This may be the final conclusion, but when it comes to URSO, the trial design was as such that it allowed URSO in the trial. So 1/4 of the patients did not have URSO, were URSO naive, and surprisingly, those patients had a better response to NCA than those who had the combination. So this may open some question marks, for a patient who is presenting de novo. Probably I would, suggest to use NCA alone, but it would not discontinue URSO in a patient who is doing well and add NCA as it was done in the study.
I think pharmacologically, everybody agrees that combination therapy will be the future, hopefully, to get us to that next level. What's, again, a challenge is developing combination regimens to get approved is challenging. So I think what we're going to see is a fair amount of plus and minus, but hopefully we'll collect the safety data and people will follow it closely. We are going to see probably combinations of things like maybe bezafibrate in Europe with Norso and different things that are being used already off-label. People are going to experiment, and our only hope is that people do it in a methodical way, that the data is collected so that we can actually evaluate, are we doing harm or are we doing benefit with these combinations? But I don't think we're going to be able to hold it back, I think, unfortunately.
No, absolutely, yeah. And I think we have to be careful that the real world data which we collect curated and monitored in a way up to
very
the
closely.
standard which we have in clinical trials.
Yes.
Otherwise,
Yes.
we have witnessed with OCA and PBC how sensitive regulators are about the quality of data in real world courts. But I think we are on good track for that.
Yep, I agree.
But now
And
maybe since
sorry, Cynthia.
I was going to say, since Steve mentioned bezafibrate, I think that's a window for us to talk about the PPARs, right? Because and linking Michael's comment about the need to have it done in a structured way that can be accepted by regulators in the future, and that we can truly assess the safety and the efficacy of the drug. So let's talk about PPARs, because let's not forget, also presented at EASL, we had the Elmwood trial. Phase 2, I know, much shorter than the NOR-URSO data, but very exciting, positive study as well. So that was elafibranor, a PPAR alpha delta agonist, and that was studied in a 12-week randomized controlled fashion with positive results. We had more than 50% improvement or reduction in alkaline phosphatase. We had stabilization of the non-invasive markers of fibrosis in that study. So 12 weeks is a very short period to assess fibrosis, but we did have some stabilization compared to placebo and improvement in pruritus for the overall group, all in a dose-dependent fashion, that led into the open label extension that is now ongoing. And you're going to hear in the liver meeting the results or interim results of that open label extension confirming the randomized controlled trial data, the double-blind data. So also very exciting. The safety profile has not changed. The drug is well tolerated. And it's impressive also in the small subgroup of patients with moderate to severe itch. It's a small number of patients. We cannot make any hard conclusions here, but we do see a trend towards improvement in itch in that subgroup of patients as well as the all-comers. So that's, and let's not forget about the Fitch study, right? That studied bezafibrate for itching specifically, not only in PSC. The study included patients with PBC, PSC, and IgG4 related disease. And for all three subgroups, we saw improvement in itching, clinically significant and statistically significant improvement in itching for the bezafibrate treated patients. We also have real world data, small open label case series studies that also show benefits of fibrates, which are PPAR agonists in PSC. So that's also a silver lining there. We're hoping we're going to see phase 3 trial with elafibranor as well.
Yeah, absolutely. I mean, go ahead, Stephen.
No, I was just going to say, I mean, the community in general is just happy to see successful trials. We have had decades of companies and drugs coming in, long-term commitments to studies, and then more disappointments than successes. So these two trials are very exciting to the community. But I will also say we are very pleased to start to see some trials based on symptoms. And so we've got ongoing IBAT studies that, and one of them that potentially could lead to an approval. The VISTA trial is looking at a compound that's similar, that has been similarly successful in other forms of cholestatic itch in pediatric and adult patients. And so we think there's going to be a high probability of success. You never know in drug development, but we're just pleased to see a pathway also not just focused on longer term disease outcomes, but some of the immediate needs for patients, in particular pruritus. And we're also starting to see there's a couple of drugs that are being considered for fatigue as well. So some exciting times to balance that, but we're just happy to see things. We want somebody to get across the finish line at some point.
No, absolutely. I mean, both IBATs and PPARs, I think, are interesting strategies. I mean, bezafibrate, we use it according to the clinical practice, EASL clinical practice guidelines. It's, the beginning of treatment of pruritus. So we already have a lot of experience, and also, as Cynthia alluded to, some real life data that patients also improve alk-phos under bezafibrate in addition to the itch. I'm personally very excited, to see, and maybe Cynthia, you can tell us whether there's also a fatigue signal with elafibranor as there is with PBC. I think that would be a huge unmet medical need. Exciting to see where this field is going. Very strong phase 2 signal, I agree.
Yeah, we don't have that information yet because of the number of patients. We cannot make any meaningful conclusion yet. But yes, definitely something we're paying attention to.
And maybe I can ask a question, because you all talked about how important cancer risk is to our patients, and how it's something that is really difficult to face. How are these therapies going to change or modulate cancer risk? Are they going to have any impact, or is it going to be more that we're going to be looking at symptoms and biomarkers? What do you think?
Well, of course, we hope that there's an impact by controlling disease, by controlling inflammation and fibrosis, that we also have an impact on the cancer risk, but this will be very difficult to demonstrate in a clinical trial. You know, it starts with which cancers do you still consider, you know, to be relevant to the drug regimen. We know that, for example, cholangiocellular carcinoma a lot of them manifest within the first year after disease manifestation. Do you count these? Probably there will not be an impact of the investigational medical product on that. So this is, in terms of study design and also duration, I think this only can be answered by real life data.
But if we prevent progression to cirrhosis, we will certainly decrease hepatocellular carcinoma, which is not a large subset. It's a small, very small minority, but we can, that only comes on patients who have cirrhosis. So we'll be able to minimize that.
Yeah. If anything right now, I mean, it's so important to screen patients who are even possibly at risk for CCA going into a clinical trial right now, because the challenge is if those cases come up, they're random, you know, and if they happen during the study, it can honestly cause a lot of complications as to whether is it drug or is it disease. And these are the types of things that unfortunately regulators always go on the air of caution, and we may be, you know, stopping drugs that are very successful for something that has nothing to do with what the drug's actually doing or not doing.
Yeah.
I mean, power and number of patients is a key issue. And I just want to point out, you know, the data presented by the Dutch PSC network at EASL. There was a poster at the last EASL meeting, and actually, surprisingly, they showed a reduction of, you know, an improvement of survival by ursodeoxycholic acid with all the controversy. And the major impact was the impact on cancer in this study. This is very interesting. It just simply shows that there is a signal in real world data which may be caught.
Now, I'm conscious we've already been talking for more than 30 minutes, so I'm going to move on just to the last part, really. Obviously, we've talked about an awful lot of exciting things going on and things that patients can expect, and also the hepatologists treating them. But what will be your other sort of pointers for what we can expect in the next 5 years in the field? Can we do a little bit of horizon scanning? What else is out there that we can look forward to seeing or hearing about? How about you, Cynthia?
Yeah.
Well, aside from seeing these trials coming to conclusion and hopefully opening a new path for therapy, so we have different mechanisms of action being explored. The immunomodulators, it's very exciting data with the nebokitug data, decreasing macrophage-induced inflammation and decreasing the profibrotic impact. I mean, it's very early. We only have data from the 15-week phase 2 trial, and now in AASLD, the liver meeting, we're going to see the long-term extension, also possibly stabilizing progression to fibrosis, but it's a different mechanism of action that is being explored. That is very exciting to us.
Oh, wonderful.
Yeah.
And what about you, Stephen? What's on the horizon for you?
I think linking to the discussions we've had about CCA or cholangiocarcinoma, there's a flurry of information led by Jesus Benalis and his group, but there's a lot of new diagnostics that are highly specific and sensitive, it looks like, for diagnosing early detection of CCA. And I think that could be very exciting in terms of, you know, identifying patients at risk, but also connecting them to care earlier, be it potential oncology care, transplant, increased surveillance. There's just a lot of things that would be improved with just a simple blood test, and the accuracy of it to give the clinicians the confidence that they've, that you actually are either ruling in or ruling out cancer would be a game changer. And this was presented at EASL and in the general session, and I haven't seen as rousing of an acceptance of new information like that in a long time. And the community is very much behind that as well. So that's exciting for us.
That's wonderful too. And anything for you, Michael?
Yeah, I agree. Those are very exciting data. I mean, we haven't talked about microbiota yet. We all still think that disease is starting in the gut, and of course, dysbiosis and change in microbiota plays a key role. I know there's a lot of excitement about vancomycin, especially in the US. I hope that we'll have clinical trials, prospective randomized controlled trials really showing or testing the impact of vancomycin. Other strategies targeting the microbiota, including not just antibiotics or FMT, but even bacteriophage therapy, modifying the microbiota composition. And at the end, I think for all those immune-mediated or also gut-focused therapies, probably we have to start treating the disease earlier. I think I'm always. We quoted Michael Manns at the beginning with the black box of hepatology. Another famous quote of Michael was, PSC is the cirrhosis of the bile duct. And that's where we stand. We are treating the end stage of a disease, and maybe we should get rid of the sclerosing in the PSC as we got rid of the cirrhosis in the PBC. But that would be a totally new definition, moving away from cholangiograms. We see a lot of signals and imaging in patients with IBD before they have cholangiographic changes, probably reflecting early inflammation. And at the end, I think in order to be successful, we have to treat the disease before fibrosis at the stage of inflammation. But the question is how to define that, probably radiologically with new biomarkers, a lot of exciting things to do in the future.
Wow. So, I mean, I think we could have had 3 studios in a row covering all of what we've just been talking about. It's incredible to hear all these perspectives, but unfortunately, all good things have to come to an end, and we have to draw the studio to a close. So, I would like to thank Cynthia, Stephen, and Michael for sharing your wonderful insights and expert knowledge today. And I know I've learned a lot, so I'm sure our community will also have a lot to take away, including hopefully patients who are listening in as well. I hope that there's been something there for them too. So thank you very much, everyone, for listening. So next week, just to remind you that the studio will be looking at how you can maximize your chances of publication in the JHET reports, if you want to listen and take notes there. So that's something a little bit different on a topic. And finally, to remind you all to become an EASL member and join the EASL family. So thank you very much, everyone, for listening. And I bid you a good day, good evening. Take care. Bye-bye.
Thank you.
Bye-bye. Take care.
Bye. Thanks.